I don't think it'll replace jobs. I think we still have to have critical thinking. You still have to be able to tell AI what to do because it could be AI, but it's not going to know the little nuances and things like that. You have to be able to say, I mean, I've argued with AI for months on things. No, I need it this way. No, it needs to be this way. And it's like, and I'm like, you're wrong. And to tell AI it's wrong, it's like, oh, yeah, you're right. Sorry. That's a response back I get. I I absolutely, my daughter is 30 and will not touch AI. She wants no part of it. I think it's a tool in your toolbox that you can just go get and use and use it for good.
It's a great thinking partner, you know.
It is.
You go back and forth and you come up with some good stuff.
Absolutely.
On Inside Pharma Leadership, I talk with leaders and practitioners across healthcare and life sciences about what it takes to lead, perform, and execute in complex environments. Today, I'm joined by Lorrinda Gray-Davis, whose work sits at the intersection of leadership, access, and lived experience. Lorinda's career spans multiple industries, including senior roles focused on people, culture, and inclusion in large, complex organizations. That background shaped how she thinks about systems, leadership, and execution long before healthcare became personal. Today, she's best known for her leadership in transplant advocacy and for building practical tools that help patients navigate medication, access, and long term care. In this conversation, we'll explore how leadership decisions, system design, and human behavior come together and what it takes to make support systems work in real life. Linda, welcome.
Thank you.
So, walk us a little bit through your background and what got you up to this point today.
So, first of all, thank you for having me on the show and to talk to you. My background is in construction, and I worked in construction for over 20 years. But during that time, in your 30s, you think everything's great. And I went to the doctor and I had high liver enzymes and didn't know why. And they could never figure it out. Fast forward 13 years later, 14 years later, they're like, I have a doctor telling me I have fatty liver disease. And then speed that up. I was living in Arizona, moved to Oklahoma, and was then diagnosed 6 months later with end stage liver disease. And it was a shock to me. And months later was inoperable liver cancer. And when I got that diagnosis, it was overwhelming to say the least. And so that whole journey has really pushed me in the direction I'm going today. And that's making sure that I'm available to help people through the process of going through an organ transplant. No matter what type of organ, we all feel the same way. Making sure they have access to their medications, especially after they have gotten their transplant, and making sure the policy, really looking at the policy side of it. I am vice chair of the Patient Affairs Committee for the Organ Procurement Transplant Network, and that sets policy for the United States.
Well, Lorinda, thank you for sharing that story. I know there's a lot there. I want to zoom out a little bit because you talked a little bit about policy, and I know that there have been some policy changes in the last couple of years. There has been the Inflation Reduction Act, there's been the HR1 bill. I know that that's had some impact on things like transplant and some of these chronic diseases. Tell us a little bit more about some of the impact that you've seen with some of those bills and maybe some other policies that have impacted some of the work that you're doing.
I think a thing that's really affected us is we actually TRIO. I'm president of Transplant Recipients International Organization, and we have a public policy committee that actually meets with the Part D. We have a Part D meeting that we attend and that we're part of with multiple organizations. And that is to make sure that our medications are still available no matter what they're passing in Congress. We are there to fight to make sure that access to immunosuppression and, not to have step therapy. So step therapy is something that is really hard on patients when actually it's hard on any patient when they say, no, you have to take this medicine instead of this medicine. And if that doesn't work, we'll give you then pay for your medication. And I think that's very frustrating for patients. And that's something that we fight for constantly is to make sure we have access not only to medications, but also to testing. We're very involved with the MolDX They changed a billing article, and we got involved with Honor the Gift Coalition, and I got to engage and co-lead with that, along with health equity and transplant with I'll Be Sure. And it was for non-invasive tests for transplant patients, and it's really for lung, kidney, and heart. Liver's not involved yet, but those tests are coming forward, but non-invasive tests so patients don't have to go and get biopsies. So there's a lot of things that we have to watch is that access. It's always access for patients.
Yeah, access continues to be a challenge, I think, within the patchwork of reimbursement that we have in the industry. And, I think you're spot on when we talk about patients having access to testing, which is becoming a little more difficult now than you would think, just in trying to figure out what patients to be getting. And then from a medication standpoint, step therapy, managed care organizations look at step therapy as a way to save costs. But when you look at the total cost of care, sometimes having better treatment earlier is a better option for patients than waiting.
It absolutely is.
So you've worked across a lot of different environments, from large organizations focused on people and culture to patient advocacy and healthcare tools. What leadership principles have stayed constant across all of that work?
See, my constant has always been so my background in construction, worked on airports, semiconductors, hospitals, casinos, and ended up, I was a project manager and then director of diversity. And I had a very diverse group with me. And we actually worked together. It was not like I'm the leader and you have to do as I say. But I think that engagement of holding people accountable and helping them achieve. I want them to take my job. And anything I do, I want someone else to be there to back me up because I need you to know more. I don't need I'm not gonna be the only one in the room. I better not. We're in trouble. But I think making sure people have access, again, access to be better in what they do, whether it's volunteering, whether it's working. I think you build a team, and I want someone to look at my team and not see who's the leader because I can't tell who the leader is because everyone's the leader.
What would you have done differently in some of those roles as you kind of look back?
There's so many things that, as you get older, you gain wisdom and the wisdom to know the difference. And so there's some things I probably would have changed, but I would say that communication, I think, was probably one that I could have changed. I think communication in any sense is always changing. And back then, if you labeled a file or you may have sent an email and people read things in their own mind about, oh, what does this mean? And so sometimes the conversation is better than sending an email because people can't put context or emotion on it when they hear with the voice. So I think that's something I would have changed, for me at least.
So, and follow-up question to that, because I know with COVID, it changed a lot of how we communicated. We were all at home, Teams, Zoom meetings, those type of things, and meeting in person, not as much as before. And as we've moved forward, you have a lot of organizations that are asking people to come back into the office. How have you changed your communication relatively to more things being virtual versus in the past where you were able to do some of these meetings and have that context of being able to see people in person?
Actually, I think that's where some of my advocacy took off is in the virtual space and understanding peer to peer and wanting to make sure that patients had access to be able to come to a meeting and share what they needed to share, or even patients that needed to go to AA that didn't have an opportunity to go from their hospital bed, from ICU, and making sure that they had a place to go virtually because sick patients don't want to go anywhere. And so basically, we've taken off on a virtual level, and I have patients from all over the United States, and we come together in one meeting twice a week, and we talk about things, and it may be coming from another hospital or another system, but the same things echo. So there's always those same points that patients all feel no matter what area of the United States they're in. And we do have dietitian that comes on because diets are always important for patients. But I think that the virtual platform has been wonderful, but I also love seeing people in person and then go, "Oh, you're a lot taller than what I thought." Yeah.
I know we talked a little bit about your journey earlier. As a patient, how has that shaped some of the advocacy work that you've done from a patient perspective and with that patient's eye?
From the patient perspective, when I started my meetings for patients, I didn't want them to go through what I went through. And so it was the landing in the emergency room and not having a map. So I think of when you get sick, it's like going on a safari. So when you go on a safari, would you go? If someone said, "Here, you've got a free safari," most people would say yes. But if you say you can go, but you will not have a guide, their hands tend to come down because no one wants to go on a safari without a guide because you could get eaten by an animal, you could die in the desert, all kinds of things. That's the same for a hospital or for a patient trying to navigate a system. It's like going on a safari without a guide. And so when I get to educate patients or get to educate people the steps to take to help them in their journey, it is amazing. It is wonderful. I get the feedback from patients or from their families that, we wouldn't have known to go in this direction or gone into this direction or another direction. And I think that's what we lack a lot of times is you have a lot of people giving you information. And if you're a patient and you're sick, you're not necessarily taking it all in. I like to have patients, I like to call patients caregivers care partners because I think that a care partner gives themselves permission, not as a caregiver, but as a care partner to stand in between the doctor and the patient. And for me, I am a horrible patient. I want all the care. I don't want to engage. I mean, at least I know that. And that's why I came up with care partner because then I'm like, oh, in my mind, I gotta change. I need to be more involved in educating patients on that or educating the care partners and bringing them together to be able to talk about their frustrations and their mental health and the mental health of the patient. I mean, it's just on a broad scheme of things. The things that are talked about are always just you would think that would never come up. And we talk about we have patients that may have had a transplant and they meet someone else that's a transplant patient and they get together and we have to talk about sex. We have to talk about things that people don't want to say out loud because we're like, hey, this is life and death for us.
Yeah. If you were giving a message to a physician, what would you tell them in regards to how to engage care partners?
I would have them engage the care partner as they would the patient at the same time and let them know that they have that privilege to stand in the center and that is as a caregiver, that's part of their responsibility as a care partner. I think patients are so used to being the lead and the caregiver being behind that we need to change that outlook and that thought process.
Yeah, I think that's a really good point because as a care partner, it's easy to get kind of lost in the shuffle. And sometimes the patient's not in the position or even have the knowledge necessarily to be able to have that conversation. I think of it in terms of being kind of that sandwich generation where you may have older parents, where having those conversations with them where maybe they're not as familiar with some of the technology, some of the tools and resources that are available. The care partner becomes a very important person in this whole treatment process.
Absolutely. I really, and another thing that I always bring up, if a doctor would ask, you know, certain things, a doctor only has a certain amount of time to come in and talk to you. And I'm always talking about fight songs because patients come in depressed or they're
Mhm.
upset. And I'm like, well, do you have a fight song? And then I ask this all the time because people will stand back and they think, they're like, well, yeah, I do. I do have a fight song. And it's amazing that when patients, they find their fight song, that's the one they listen to and they can go into battle with. And, it's pretty amazing to watch the patients. We actually have a trio fight song playlist for patients that they
Yeah, that's
put their
cool.
songs on there.
Yeah, that's cool. It's a good way to keep people motivated.
Absolutely.
So obviously, I spent most of my career on the pharmaceutical side, on the commercial side of the business. If you had a megaphone that you were able to talk to some of the pharma companies that provide some of the medications, the testing, and those type of things, what would you say to them that would be helpful for not only physicians, but patients as well as care partners? What would that be?
Well, I'm glad that you asked that question because I just built Transplant Medication Navigator and I'm putting out Medication Navigator in the next month. But nothing's ever been in one place. I don't know who makes this drug. Most patients don't know who manufactures the drug, so they don't know to go get a copay card. They don't know to ask for patient assistance. They disqualify themselves without looking to see if they would qualify for free medication. Most of them, probably 80% would qualify when they fall into the 4 or 500% of the poverty level. So there's a lack of education when it comes to how do I get my medicine? Because I can tell you, I went to the pharmacy to get a drug and it was going to be $624. And I said, well, didn't you check? Isn't my insurance on there? And they said, oh, here, let me put that on there. It's $195. And I said, oh, no. And I was smart enough to know the manufacturer, got on my phone, got a copay card. I gave it to her. It was $10. So it went from 624 to $10. But at the $195 mark, I was not told that I had an option of a copay card, at an option of something else. So for me, how many people would have walked away? How many people would have cried at the counter like I have before? And it's how do we make sure that they understand how to navigate. And so that's where Transplant Medication Navigator comes into play because it pulls over the drug, it pulls over the manufacturer and makes sure that if they have certain insurances that copay cards will come pop up. Here's a patient assistance program. Here are foundations. Here are grants. I think we've missed education in the space.
Yeah, that's important, trying to educate patients, physicians. And I think even though pharma spends a lot of money on tools and resources, it feels at times that it's not enough, that people still are not aware of some of the tools and resources that are available for patients and where to find them. And I think you're right. You can go to a half a dozen places, and you can find a half a dozen tools, but oftentimes all of those tools aren't consolidated in one place. So I know that that's a big challenge.
So
What
that's
what
what I did. I put it all in one place. Appeal letters, how to
Okay.
poverty lines, how to look at Medicaid for every state. So I have Indian Healthcare Services, TRICARE. I mean, I have it listed just so patients can understand and not, go, well, I have a certain name insurance. It's
Okay.
either this or this.
Alright. Alright, yeah, and that's good because, and I think through, a Medicare patient is gonna look a little different than somebody that, they're a veteran, you know,
Right.
or somebody that's not necessarily a veteran, but somebody in their family has been a, veteran and they're getting TRICARE, those type of things. So, yeah, it sounds like a great tool. What was kind of the brainchild behind that? What kinda made you decide to go in that direction of that tool?
Let's see. In 2020, I wrote a paper, copay cards versus grants and
Okay.
foundations. And so that is actually from that paper that I wrote because I wrote it for our Trio, Oklahoma patients because, I didn't understand it. And once I started understanding, I was like, okay, but where is this out there? And so I wrote a paper and published it just, online with friends, and I wanted to make sure that we could understand what was going on. So out of that brainchild came Transplant Medication Navigator, and I thought, well, if it works for transplant medicine, it works with all medicine. So that's why Medication Navigator is coming up.
So how easy has it been for people to get that tool?
They just have to go online and it's free. So right now, I'm the one paying for it for patients to be able to have access, and
Okay.
that's not sustainable. But I feel like that this is more of a software as a service, and be able to have patients. But I think transplant centers or hospitals could educate their patients and use that
Okay.
as one of their tools for educating and not saying the same thing over for every day for 20 minutes a day to patients, and say,
Yeah.
"Here's a platform."
Sounds like a fascinating platform.
It is. It's everyone that's opened it said, "How?" I'm like, "That's how my brain works." When you need medication, your brain starts working.
Right. So I guess the next step will be to figure out how to get it to the masses without you having to pay for it.
Right.
So I'm sure that'll be a good next step. So let me see here. So I'm gonna change direction just a little bit. So when support tools succeed, what's usually true about the leadership behind them?
When support tools succeed, I think it's the leaders really taking a look at what is happening, the big picture of whatever project is going on. I think sometimes we don't think out of the box because we can have a tool and everyone's like, this is the one. And I had that instance in construction, and I had a thing called Yet to Buy that I wanted. And it was something that I learned at another company. What do we have left? What is out there? And so on a big project, a $6 billion project, for some reason, no one knew how much steel we needed to buy that was
Mm,
left to buy.
mm.
And I had someone in IT put me together something that would pull all the information in from the 30 projects so I could see exactly where we were for my department and what I had to do. And I ended up getting a phone call saying, "Hey, Lorrinda, we hear you have a tool that we don't have." And I said, "Yeah." And I was able to give that to them. And it was just thinking out of the box, thinking, okay, what, because I think others can see something that maybe you can't sometimes.
Yeah, yeah. And having those tools and technology available are important. How much is AI played into what you're doing today?
Oh, I love AI. I love to work with it. I like to work on it with different platforms, different AIs. I'm not sold on one. I think they're all great, but I think you get what you put into it. So if you don't know what to put into it, that's what you're going to get out of it. So I like to play them against each other. So I can get, if I'm working on something, what does this look like? It's helped me actually with my transplant medication navigator. It's health literate. It's a sixth grade education. Anyone can go on there. It's got the disability. AI helped me with that. And it's all coded. It's not something that it's put together on a Wix platform or anything like that. It's actually coded and I had to learn, but it was a mission of mine to learn it. And I wanted to throw the computer outside on the street a couple of times. I may have cried at one point. And then the one point I was going to cry is when it came up and it was live. That's when I wanted to cry because it was like, it's working.
A follow-up question to that, Lorinda, because I know a lot of people have been afraid of AI, and in their minds, it's going to replace people. I don't believe that. I think it amplifies what you know. But what are your thoughts on that?
I don't think it'll replace jobs. I think we still have to have critical thinking. You still have to be able to tell AI what to do because it could be AI, but it's not going to know the little nuances and things like that. You have to be able to say, I mean, I've argued with AI for months on things. No, I need it this way. No, it needs to be this way. And it's like, and I'm like, you're wrong. And to tell AI it's wrong, it's like, oh, yeah, you're right. Sorry. That's the response back I get. So I absolutely, my daughter is 30 and will not touch AI. She wants no part of it. I think it's a tool in your toolbox that you can just go get and use it for good.
It's a great thinking partner, you know?
It is.
You go back and forth and you come up with some good stuff.
Absolutely.
So when you look at the medication navigator that you're using, when will you feel like that is beginning to take root and that it's having the type of not income, but outcomes that you're looking for? How are you gonna measure that, so to speak?
I think, when I was testing it and having people look at it, the patients that tested it were like, "Oh my gosh," I would go and then I go to ask this question and it was there and I went here and it was already there and I wish I had this before my transplant and I cannot wait for this to come out. Those patients, that even handful of patients, I know that it's going to do good. And for me, it's just getting the word out. We're still testing it, but I think it's just when I can get hospital systems to use something to educate their patients. I think that's going to be successful. Right now, I say it's successful because it's already helped someone that they have access to it and that it is free for them.
So it sounds like proof of concept definitely is there. How easy has it been to sell to hospitals?
Well, that's where I'm at. That's where I'm starting from. And so for someone that's not in sales, I've never been in sales, but this is something new. And I know that patients would use it. I have had social workers look at it that said, "Oh my gosh, you don't understand how much this would take off of our plate." And doctors have looked at it and said, "Oh, can you add this and take off this?" And so I know that it's a tool that could be used. And so for me, the next step is getting it into hospitals, getting someone to take the chance, do that first time.
Yeah, I think that's definitely doable. I think, based on what some of the hospital systems and things are looking for, there's areas that they definitely need help with. So, yeah, it makes perfect sense.
And recreating the wheel. I mean, if it's already done,
Right,
I
exactly.
see
Why
it,
do it?
you don't have to do anything. Just.
Now, have you thought about partnering with any pharma or life science companies at all?
I have not yet. I would, you know, take that into consideration, but I have not reached out to anyone. I wanted to get transplant medication navigator going first and then put out medication navigator and really look at that side of it versus the transplant side because the transplant side is a very small piece of pie
Sure, yeah.
out of the medication side. So, on the medication side, I'd love to partner with pharma companies, life scientists, things like that. But I'm trying to keep it patient led, patient focused.
Yeah, because it's designed as a patient tool
Correct.
to get, help patients to be able to navigate the system. And it makes sense because it it's a win for everybody. There's a high percentage of patients that get medication, but they may not necessarily take it. And it's not necessarily always transplant. Sometimes it's the garden variety, high blood pressure, other types of medications for chronic diseases that patients may not feel. They feel that they're serious, but they're challenges and maybe they don't feel the immediate facts. And so those are scripts that don't necessarily get filled and that patient's not treated. And those patients oftentimes put a lot more money back into the system when we talk about cost of care for some of these chronic diseases.
Absolutely. I put together the deductible trap, and the deductible trap is based off of cards that are GoodRx or single care that really, use them at first because the deductible's so high. But by the end of the year, you've actually spent more than you would have if you stuck with your insurance. And so a one off is always fine. But when you use discount cards, you're not really getting that discount that you should. So, I think one of the main things I put together is a graphic that has what commercial insurance, what you can get, a copay card,
Mm.
grants, foundations, you can stack it. People don't understand that you can stack your insurance. Or if you're on Medicare, what does that look like? There's no copay card, so that goes off. So I have that in the graph for everyone so they can see, and even uninsured, and what they can go after. So for me, I guess it's all about the knowledge of the how to,
Yeah, makes sense because when you think about Medicare, for example, you have Advantage as well as
which is
regular Medicare, and there are different rules depending on what you have. And a lot of
right.
patients are not necessarily aware of that.
So the deductible trap is one thing that they really liked because they said most people don't address that, and of course, the Inflation Reduction Act, that was 2,000, now it's 2,100 for the year. And so if one patient goes and gets a drug, and I have to say that I've done this, I went to go get my medicine and it was $80 with my insurance, but the cash price was 19. Now I'm going to pay $19,
Right.
but that doesn't count towards my deductible. And so making sure patients understand where it's okay to do it, where it's a good safe place and where it's not a good safe place. But it's always about what they're going through.
Yeah. Well, it's great that you've put so much time and energy and effort into thinking about the tool and making it a tool that everybody can use. So you can download this on, I guess, in your app store?
It's a website, but you can look at it on your phone. Like it's a progressive web app. So you can still look at it on your phone. You don't have to download anything. And we don't take your name. Well, we get emailed, but we will email you what the plan is or where to go to. So you actually get that in your email also. But if you go through the My Path quiz, it'll give you the information and it emails, but we just ask for email. Otherwise, we don't collect. We don't know what medications you take. We don't want to know what medications you take, but we want to
Yeah.
make sure you have access to the medications you take.
Okay. Great. Great. Well, Lorinda, I appreciate you joining me. Where can people find you?
They can find me at Old Davis. Let's see. I have a website now, LorrindaGray-Davis.com, and I have a transplantmedicationnavigator.com or TRIO, Transplant Recipients International Organization.
Great. Well, thank you so much. Thanks for joining Inside Pharma Leadership. And I will have all of that posted in the show notes and everything. And hopefully people will reach out to you. So thank you very much.
Thank you.